understand by abnormal uterine bleeding? Yes, Amar Singh, YA, no, YV. Yes, Amar Singh, are you there?
Hello, sir. Yes.
Yes, yeah. Tell me, what do you understand by abnormal bleeding?
It may be bleeding from in a irregular time,
Okay.
also
Right.
longer
Okay.
than usual or in a usual time.
Right. Yes. Right. Very good. Right. So when there is longer periods, you call or irregular bleeding. Right. But anyway, the the nomenclature that we use is abnormality to be defined as now any variation from the normal menstrual cycle. So it can be regularity change, it could be frequency, it could be duration, or it could be the amount of blood loss. So any of these four components, any of these changes from normality, we have to think about what we call we have to define it as abnormal uterine bleeding. So to define abnormality, you have to know the normal, obviously, right? So then only we know what is abnormal. Right. So one normal is a regularity. So we talk about four components. So how often the periods are coming. So and what is the duration of each period when they have the menstruation? How much of blood they are using for how long? Right. So those are the basic the four characteristics that we look for. Right. So one is if somebody is having a period, let's say it's 28 days, it should come every 28 days. The difference can be only about plus or minus 3 days. So somebody who's regular bleeding at 28 days can have a 25-day cycle or a 31-day cycle. That's it. But in between, most of the time it should come on 28 days plus or minus 3. Now, frequency means how often they are coming. So anybody who's having a cycle at 21 days should have a 21-day cycle plus or minus 3. Anybody who's having a cycle of 35 days, it has to be plus or minus 3 days. So like 21 to 35 days, we still consider it normal. So if somebody is having a cycle of 21 days, only difference is it has to be coming on 21 days, 28 days, 35 days. Likewise, whatever your day, it has to come in a regular manner. Now, 21 days is minority of patients or women. 35 days is minority of patients. Majority will have what we call 25 to 28 day cycle, 25, 40, and by about 25 to 35 years, 60% have a cycle of 25 to 20. That's why we say that monthly bleeding, because majority of the women will have a monthly bleeding, but not all will have it. So minority of normal women who will have a frequency who are having a 21-day cycle, or somebody may have a 35-day cycle also, which we consider them to be normal. However, when you are above 40 years of age and when you are less than 18 years of age, usually your cycles can have irregularity and they can be prolonged in the sense they can have even 35 days, 36, 42-day cycles kind of thing they can have, but we consider them normal. But this is the normality we are talking about. So anybody who's having a cycle less than 21 days or more than 35 days, we consider them to be abnormal. Duration. So when you start bleeding, it should at least last for 3 days to a maximum of 7 days. Majority will be only about 4 to 6 days. So if you are bleeding more than 7 days, it's abnormal. If you're bleeding less than 3 days also, it's abnormal. Right. And the one of the 3 things I have to tell you today is, now once I do this lecture, I usually get medical students coming me in the either private sector or in the hospital to ask about their menstrual cycle, because like I will come there, why a significant number of you will have problems in menstruation. So that is not something you have to be alarmed of. I will tell you, because most of the time it's due to stress, right? So I'll come there, but this is the regularity that we are talking about, right? The flow should be about 36. That is about 3 tablespoons throughout the pregnancy. That is the normal flow for the 5 days, 3 days or 4 days, 7 days. That has to be there. If it is more than 80 ml, it starts to reduce the blood levels. Now, do you know how we came across this 80 reduces HB levels? So, how do we know that 80 ml of blood starts to reduce HB? Any idea? So we consider this 80 ml is a very important number for us, right? So this 80 ml, how did somebody find out that the normal menstrual flow should be less than 80 ml? Any idea? Let's ask from Dayaratna. Yes, Dayaratna. Ko Dayaratna is sleep in the Taroshi Jayaratna. Hello, can you all hear me? Yeah, Taroshi, tell me.
Actually, sir, I don't have an idea.
You don't have an idea, right? Okay, now let's say if you are asked to check the amount of bleeding your batchmate has, like let's say you want to just do a study, you want to know what is the average amount of bleeding your batchmates are having, or medical students are having. How would you design a study for that?
Using the number of menstrual pads we are using, sir.
So the problem with that is some may change it very quickly, some may change it late. And some may use about 30 pads per day. When there's only a little bit of bleeding, they will change it. Some will, when the pad is dripping also, they don't change, and then they change about 3 pads for the whole day. Okay, I will tell you, because this is one of the fascinating things about medicine. So one long years ago, one person did a study like that. So this is going to be the last time somebody is going to study like that, because at the end of his study, he lost his marriage. His wife divorced him. And there was a name for, like, the people stopped going to his, what you call the lab also. What he did was, he gave women, the study population, a significant number, about 2,000 women, sanitary pads and a shopping bag. So what they were supposed to do is, whenever they have when they are menstruating, when they change the pad, they put it to this what you call cellophane bag, and just tie and kept it. So at the end of each menstruation, women used to bring these bags to him. So you can imagine, some are 3 days old, 4 days old, 5 days old, 7 days old, whatever the day. So there were certain things that they have to mark. Apart from that, they just gave the pads and gave it to him. What then he did was, he had a washing machine where he put each shopping bags inside this packet, because he know the dry weight of this the pads. And also what he did was, when he put them into the washing machine, they washed them inside. So then he knew the amount of water going into the washing machine, and then the dilution of whatever the blood in it. So he take a sample from it. So they has a what we call chromo. There's a way of calculating the concentration of hemoglobin or blood in that water. So out of that, he calculates, he knows the total amount of water and how much of. So in each day, each packet or each set of thing, how much of the blood the woman has, passed. So that was there, but you can imagine. So the whole, he was doing this study for 2,000 women is long study period time. And what he found was this. And the same day he used to take before the period and after the period blood samples. So he found that when the hemoglobin level or when the bleeding is more than 80 ml, their hemoglobin start to drop. So now then we consider that 80 ml, less than 80 ml is normal, more than 80 ml is abnormal. That is how this 80. So we cannot do this study again ever because it's too cumbersome. Right. Now, just to remember, recap, you remember your physiology, the reproductive health, what you call the physiology time. You remember that hypothalamus, there is, from the hypothalamus, there is GnRH, and the GnRH will act on the pituitary gland, anterior pituitary gland, which secretes FSH and LH, which works on the ovary and produce estrogen and progesterone, and this will inhibit the pituitary gland and the hypothalamus, right? So that is the normal, what we call HPO axis. And now you remember why the reason. Now you can see this hypothalamus is under the limbic system, or what we call our thoughts and our stressors, or all this we can interfere with the hypothalamus. Right? So hypothalamus is under control of all these our neural inputs. Right? Now, why does ovulation, which happens away from the body, this is head, this is way down below, right, which should produce an egg every month, has been in control with the HPO axis? What is the reason for this HPO axis? It should have been easier if there won't be any pregnancy problems also, if the ovary every month release an egg this side and the next month the other side. Why every month until the eggs are gone? Every month, whatever the time they start to end, without any control from the hypothalamus and pituitary, or with the brain, without any control from the brain, they should do that. So why do we have this under the control of this? So, what you call a very complex mechanism. What is the reason? Any idea? Yes, any idea? Anyone can guess? Let's say Bandara. Why do you think this whole reproduction is under the control of the brain? Yes, Bandara. කට්ටිය මම හිතන්නේ මේක දාලා නිදිද කොහෙදනේ? නැත්තම් නැද්ද දන්නේ නැහැ. කුරේ, BL.
Yes.
Right. Okay. So tell me, Kure. So Bandara AMJ is not here, no? බොරුඩ මෙතන බොරුඩ දාලා on කරලා නිකන් ඉන්නවද කොහෙද? Right? Kure, tell me, why is the whole reproduction is, why do you think the reproduction is connected to the brain? Tell me, what do you think? Just it doesn't matter. It doesn't matter. It may be wrong what you're saying. It doesn't matter. Why do you think?
Because it should be regulated in specific time periods, and also there's a component from emotions as well.
Right. Okay, good. Right. So actually, there you are somewhere there. Now, remember, we used to live in the jungle, right? We didn't have food. You have seen what you call the Discovery Channel or National Geographic Channel. You see that animals reproduce during, when there is, water and when there's a rainy season, usually. When there's a famine, they can stop reproduction for years and years. Now, reason is if you get pregnant during a famine time or when there's a food, limited food is available, that animal could die, right? So the way that the ovaries can sense that is to connect this to the brain functions. So the brain now now long years ago when we are in the cave, we have only one stress. The stress is when there is no food. So when there is no food, the brain, you get stressed, and that stress will stop your hypothalamus producing GnRH. It stops FSH-LH, and then you will not have a period for many years. Sometimes if there is no food for a longer time, if there is war like that time, right, during this. So nowadays, for any stress also, that's why I tell that, as medical students nowadays, you may not have a period for a year. That's normal. It's going to be normal because body perceives as there is something wrong. There is no food. The moment that the body senses there is something wrong, it thinks there is no food. No food, no reproduction, no ovulation, no periods. Right? So remember that. So that's a very important thing you all for to remember. That's why when you have some of you all will have problems with your menstruation when you have exams. You will have problems with menstruation when you have, when you are stressed, when you have breakups, when you have something good happening even, right? So you have passed the exams or you have done very well. So emotional changes, right, will, if there is any stress, whatever the way, whether it's exams, whether your family issues, relationship issues, uncertainty of the future, bad boss, what, regardless, whatever that, or your parents saying tamat faculty, and get married and all that, whatever the reason, your body will stop reproduction, right? So that's, remember, that is why the nature wise it was made to protect the animal from dying by reproducing in a wrong period of time. So that's the important thing, right? Now we will start clinical evaluation when a patient presenting with abnormal bleeding. So how would we proceed? Right. Now we used have these nomenclatures. Now we are not supposed to use them anymore, right? So when we were small, when we were like you, I remember the lecture being done. And then we were supposed to memorize all these words: menorrhagia, menomenorrhea, dysmenorrhea, menometrorrhagia, right? Oligomenorrhea. All these names were there. So many names, right? Including all these anovulatory cycles, epimenorrhea, hypermenorrhea, hypomenorrhea, polymenorrhea. All these names were there, right? So anybody could know what is dysmenorrhea, what is amenorrhea, what is menorrhagia. So there were a lot of terminology for us to use those days. But it has made a lot of confusion over the years, because what you mean by menomenorrhagia and what I mean by hypomenorrhea may be very two different things. So because it's confusing, the FIGO, which is the Federation, International Federation of Obstetric and Gynecology, decided that we should abandon this terminology for future. Now we have a very simple things. We have 4, I told you: the volume, regularity, frequency, and duration. These are the 4 components you are talking about. If somebody is coming with abnormal uterine bleeding, you try to figure it out, which are the ones which has become abnormal. So is it volume? Is it your period has become heavier? Are they normal, or they have become lighter? Regularity. Do you have menstruation regularly, irregular, or it comes more frequently, or it's not has come for some time? Then the frequencies, it's come in a normal cycle, 28 days or whatever your normal cycle. It comes less than 21 day cycle, we call it frequent. it comes more than 20 to 35 days cycle, it's we call infrequent periods, right? So there is regular means there is a regulation, right? Every 20, let's say somebody is having, will come to, let's say, 28-day cycle, it still comes at 28 days, it still come at 28 days, but still the volume may increase. Now, duration, you have your 3 to 7 days. The duration is normal. Has it shortened less than 3 days, or has it become longer, more than 7 days? Right? And then we have other terminologies like whether you have a bleeding in between the period. Is it after coitus, right? Or you are supposed to get a period, you have unscheduled bleeding, we call. Usually it's called with sex steroids. When somebody's on a what we call oral contraceptive pill or any pill, you are supposed to get a period on the dot every day. But so if you get a period without any schedule, so we can control our periods. If it comes on a day that you are not expecting, we call it unscheduled bleeding. So these are the terminology that we use now. Mainly volume, regularity, frequency, and duration is the important. So let's say somebody comes and they tell you, my periods have changed. I have heavy periods. Then you had to write, okay, very right. So like we'll first ask about your periods when you think they were normal. So that is the first question you ask. Let's go back to the time where you think your periods were normal, where you didn't see a doctor or anybody, you think this is my normal. So how long is your cycle? Is it coming on 28 days, 21 days, 35 days, or you ask the patient, say, oh, it usually comes per 28 days plus or minus 2. Okay, good. And do you get it regularly? Every month do you have it 28 days? She said, yes. Okay, good. Then how long do you bleed when you start bleeding? I usually bleed about 5 days. Right, good. And do you consider your periods to be, the flow to be normal? Do you feel that it comes, usually periods are heavy, normal, or abnormal? Have you taken any medicine for this? No. So your periods are normal. According to you, you bleed about maybe 1 or 2 pads per day. Right, good. So this is your normal. Now tell me what has happened. Are you still getting your periods regularly? The patient will say, yes. Okay, you are still getting at 28 days. Very good. Now, when you start bleeding, do you bleed still your 5 days or longer? No, now it's 7 days. Right, okay, so it has increased now. Do you feel your periods has become heavier? Yes. Now how many pads per day you use? About 7. Right, so it has become heavier. So heavy, and then do you still got it for the last few months, every month? Yes. Right. So then you will say to the patient, then your presenting would be, this patient is presenting with regular, heavy, prolonged periods. Right? Regular, heavy, prolonged, normal periods. Right? So the frequency is normal, frequent period. Right? So this is different to what we used to say earlier. So this is important. You identify what is exactly the problem, because the combinations of these problems can mean a different disease. So you have to know what is exactly happening. So by looking now, if somebody tell me that, and then you have to always ask about pain, associated symptoms like pain and all that. If she says, I don't have pain, I would think, okay, this may be very likely to be a period due to fibroids, something like that. So somebody having heavy pain, it may be due to something called adenomyosis. So something like that. Okay, right. So history is very important. So you have to establish the type of abnormal uterine bleeding what she has. So how does this affect the quality of life? So why you are here? What is the problem with having this kind of bleeding, right? And then the moment you say, okay, she's abnormal uterine bleeding, the moment you have that, your head had to start spinning and trying to find a cause. What is the cause, right? And identify whether there are any possible complications like anemia, having social issues and all that, right? And it is important by the time you see the patient, whether she has gone to somebody else, has done certain treatment before, what has done so far is also very important, because otherwise you can't proceed, because you can't start over a same treatment again which has not worked. You can't start over again. So it's important for you to establish what is the type of abnormal bleeding. For that you have to know what is the normality first, then establish what is the current abnormality you are talking about, and see how this has affected her quality of life, whether she has developed any complication related to this period's problem. Why is she having this problem? What are the possible causes for her problems? What has she done so far? These are the questions that you need to answer after your clinical evaluation of a patient, right? And if somebody is undergoing surgery, your fitness for surgery, and when we give you a treatment option, let's say surgery or medicine, whether she can afford it. If you are going for surgery, whether she can do a surgery now. There's an issue for her to undergo surgery now? Social, let's say sometimes a patient comes, let's say we found a big fibroid. We have admitted her, and a patient who's supposed to go to the list tomorrow has got cancelled because she got COVID, let's say. So I think, okay, this patient is there, shall we put her to the list? Then the house officer will tell me, I'm sorry, sir. She is the person who's, working, or the person who's doing, make shortage to be sold. And she's the breadwinner of the family. If she gets operated right now, her family goes hungry. So she needs to sort it out, and then we can operate. That's the house officer I want. Okay. Right. So examination, general examination, abdominal examination, and pelvic examination, especially speculum and bimanual. So we have to do a complete examination, thinking about the possible causes in your head. Right. So what are the investigations we can use? Right. So this is very important. Anybody coming with any period problem, you have to do a urine HCG, regardless of their marital status, whether they have achieved menopause or had had never had a menarche. You always do a urine test, because for us, all women are pregnant and have an ectopic pregnancy until proven otherwise. If you go by this, one day, I can assure you, before you retire, you will save somebody's life. One day, right? All women. It could be a nun, mehening wahansa, a teacher, medical student who says that she has never touched a hand of a man or something like that. Still, you do a urine HCG. So that is the important thing, right? Because there have been instances where we have missed this and patient has died. Because if you don't think about it and you don't test it, and it has a very simple test, just during the urine HCG, urine strip test. If it is negative, you know that she's not pregnant, and you can go and find another cause, right? So all women are pregnant until proven otherwise. Okay. Give me one moment. Right, so do a pregnancy test. That is one take-home message for you guys. Right, investigations. We want to know whether she has developed anemia. That's the commonest complications somebody who's bleeding can have. So we do a full blood count. And to find a cause. So investigations can be to find a complication and to find a cause. So the cause, we can do ultrasound scan of the pelvis, which is usually we see if the structural problem, right? Or coagulation problems, hormonal profile. So depending on this cause do you suspect, you do a investigation which is necessary. Right, and we have hysteroscopy, which is putting a camera inside the womb and see what is the problem. We can do endometrial biopsy, right? And especially if they are postmenopausal, if it is age is more than 45 years, when there's a treatment failure with other thing, and then you have a high risk of endometrial cancer, we do it. And other investigations are needed to check whether somebody is fit for surgery. So investigation in a patient who's have normal uterine bleeding can be 3 parts. One, to find complications, or let's say find a cause, why she's having bleeding, what is the problem. Second, does she have developed any complication like anemia? Whether if she is going to go under surgery, is she fit for surgery? So not all patients need fitness for surgery, right? Thyroid function and, liver, like renal and all that, depending on the what type of anesthesia and how aged is the patient. Not all patient needs all investigations also. Right, now we come to an important thing. So the clinical evaluation is important. So to do all this, you all have to know one thing, that is, what are the causes for abnormal uterine bleeding? So clinical evaluation comes with that knowledge. So what we do in clinical evaluation is what we discuss. To discuss that and to know what's happening, you need to know the causes for abnormal uterine bleeding. Right. So there is something called what we call the Palm-Cohen classification, right, system. To see, now the palm is here, right? So like the palm, so PALM. So this acronym stands for the structural problems, right? And other things are what we call Cohen means functional problems, coagulopathy, ovulatory response, endometrial. So we are going to talk about each of these problems. So these are the two main problems. Whether it's a structural problem, is it a functional problem? Structural problem, functional problem, right? So structural problems, what we call like the palm, remember, polyps, adenomyosis, leiomyoma, malignancy, right? P for polyps, A for adenomyosis, L for leiomyomas, or what we call fibroid, M for malignancy and hyperplasia, right? So we call it AUBP. So polyps, it can be either endometrial polyps or cervical polyps. Usually we can use it by the ultrasound scan, hysteroscopy, histology, or even simple what we call a speculum examination. And we put it either absent or, right, 0 or 1, right? Caution, and although often they can be asymptomatic, they can be sometimes, like usually polyps are asymptomatic. They are just there. So just because somebody is having heavy menstrual bleeding, you do a ultrasound scan and you find the polyp, it may not be the cause. That's why we say this is AUBP plus or 0. Plus mean polyp positive, 0 means polyp negative. So we have a nomenclature, we'll come there, right? Okay, so these are the polyps. So this is the hysteroscopic view. When we put a hysteroscope, we see this polyp like this inside the womb. It's like this, or in a specimen, you can see it like this. So it increases the surface area and it increases bleeding, right? And as I told you, now this is the reason the prevalence of polyps are very high, sometimes 70%. So if 70% is the prevalence of polyps, then abnormal uterine bleeding also about 70%. If all polyps cause abnormal uterine bleeding. So that is important, though they are very prevalent. So when we are putting, adenomyosis is again a common disease, right? So one in, like we say 70%, 5 to 70%. And we have ultrasound, but I'll go back a bit first. Oh, right. Now, polyp, do you have any questions before I move? Otherwise, it's going to be a problem. Any question from the polyps? You can put question to the chat also. Right, okay. Let's try adenomyosis. Right, so adenomyosis is the next cause. We call it AUB, abnormal uterine bleeding A. So there's again common disease to have, and we have MRI as well as ultrasound specific features that we look for to see whether there is diagnostic criteria. It's otherwise very difficult. And ultrasound is much more accessible than MRI, even especially true for Sri Lanka. And transvaginal ultrasound scan is almost comparable to MRI in both sensitivity and specificity. So you don't need to do MRI. You do a proper ultrasound scan transvaginal, you can come to a diagnosis of adenomyosis. So adenomyosis is presence of endometrial tissues in the myometrium. So they are, like if you look at it in the specimen, you will see as this red dark color material, black spots, and this thickens the endometrial wall, right, because of inflammation. So ultrasound's criteria to diagnose, that's something you need to check on your homework, because this is a question that we ask usually. Somebody asked a question, sir, are those polyps are benign or malignant, which will lead to, right? So it can be either malignant or benign, both can give rise to abnormal uterine bleeding. So when there is combined with the abnormal bleeding, when we find the polyp, we have to remove it and histologically test it to see whether there is a benign polyp or a malignant polyp. Okay, so until we do it, we can't find it. We have been many instances where only the tip of the polyp has become malignant. Okay, so you all have to find out what are the ultrasound criteria to diagnose adenomyosis, because it's a question. Now, this is usually asked when you have done really well in your exam, and this is usually a distinction question or a gold medal question. So people who are thinking of having gold medals and all that, look into this, because this will be important for you, right? Leiomyomas, or we call it usually fibroids, is again the commonest thing I would say for commonest lesion women will have, but not all fibroids cause bleeding. Now, this is very different to your parents, your mothers or grandmothers have undergone, right? Even I remember when we were medical students, if we find fibroids, it's usually surgery. We have to remove them. But nowadays, we don't do like that. We wait for this. And then because the thing is, at the moment, we don't know exactly how the fibroids cause bleeding. We think it's maybe increase in endometrial surface area, which is the reason why submucosal fibroids, what you call intracavity fibroids, intramural fibroids cause more abnormal uterine bleeding than subserous and pedunculated fibroids, right? So we think, okay, this may be, or sometimes it says because of the increased blood flow received by fibroids, increase the uterine blood flow, which increases this thing, bleeding. So we don't know exactly, right? And sometimes, even though they are not disturbing the cavity, still they cause bleeding. So that is why we are not 100% sure how the fibroids cause bleeding, but we know, yes, some of the fibroids can cause increase in bleeding or heavy menstrual bleeding. So we have different names. If it comes to it's just underneath, we call submucosal fibroids. These are called intramural fibroid. It could be either cervical fibroid. These are subserosal, more into the abdominal cavity rather than to the uterine cavity. And we have pedunculated with a small, pedicle. They can be even become very big. Right, so and we call it fundal fibroids, posterior fibroids, anterior fibroids, cervical fibroids. So many names are there, and usually they come in multiple numbers. And some have what we call fibroid syndrome, where they have about, like the largest number of fibroids I have removed from a single woman is 42. Right, we did it last year. Right, so so the fibroids can be very large and also high in numbers also. Right. Then we have malignancy and hyperplasia, right? So luckily they are not that common, right? If you are less than between 45 to 50 years, it's about 1%. And from 50, that's above, that is when you have postmenopausal bleeding, malignant risk increases to about 10%. But usually if you are less than 40 years of age, chance of malignancy is about 0.1%. So luckily they are not common. However, we can't miss them because endometrial cancer can be cured if we detected early, and if we miss it, it's much more, the prognosis is worse than cervical cancer. Remember that, right? Because we catch endometrial cancer early, the prognosis is good. But if you compare from what we call stage to stage, endometrial cancer is much more, have a worse prognosis than cervical cancer, right? And hyperplasia is where there is a precursor, or there are changes in cells which may indicate in the future they become abnormal cells and cancerous cells. So hyperplasia is also something we treat, or we try to remove the organ which may get. So we have hyperplasia of the endometrium, hyperplasia of cervix, or abnormal what we call cervical changes, and all these are precursors of cancer. And so that is important that we find them and do the appropriate test. Right, so we just discussed about the what we call the structural problems. That is the palm part of it. Now there are functional causes for uterine bleeding. So these are, we can't find a, we can't pinpoint a real thing. There is no structural abnormality, but they can have problems. So we call it COAN. So C for coagulopathy, ovulatory dysfunction, endometrial problems, iatrogenic that we have causing like medicine and all that. And again, as in anything in medicine, still there are certain things which we have not found a cause or have not still classified what is the reason for bleeding. Right. Coagulopathy, we think that bleeding disorders are not common in women. However, the commonest bleeding disorder is von Willebrand disease. So now I have treated about 3 patients, including 2 patients who underwent delivery also. So during delivery, it's a nightmare because they can bleed a lot, right? And it's a terrible thing to have a woman, because the treatment would be to put them on suppression therapy ever. So they should not get periods ever. So we diagnose them early usually, but they are in their childhood when they start their first period. Usually the presentation comes heavy bleeding, right? And the thing is, it's common in heavy menstrual bleeding. So that is something you have to, we think that, the what you call bleeding disorders are not common in female, right? But you have to think about von Willebrand disease when somebody is presenting with heavy menstrual bleeding, right? And the good news is, by having a structured history, a properly taken history, 90% of the time we can diagnose even without doing any test. We don't need a very high-fi test to diagnose von Willebrand disease, because with a structured history, 90% of the time we can run. And then we do a screening test afterwards for Willebrand factor, or these are the things that we check. And if they're positive, then we know that this woman is having, that is the diagnosis, right? So this is the structured history taking. So heavy menstrual bleeding since Minake and PP, they had surgical related bleeding, postpartum related bleeding, during dental work there can be bleeding, and 2 of the following, right? So bruising and all that, right? So these are you can find it in the internet. And if any of these features are there, you can think about von Willebrand disease, and then you have to send her to a hematologist for a final diagnosis. Ovulatory disorders, which is the commonest reason for abnormal uterine bleeding, either lack of bleeding, what we call infrequent bleeding. Earlier days we used to call oligomenorrhea, because out of all those themes, oligomenorrhea still have a place in our practice, because people call it oligomenorrhea. But the correct term is infrequent prolonged bleeding is the usual term, right? And they have irregular cycles, right? Usually they don't have every month cycles. Usually they are far apart, right? And they have absence of progesterone, right? If you do day 21 progesterone level, they usually low, indicating that they didn't have a luteal phase, right? And right now there are 2 things. A patient who's having irregular, like usually what we call irregular periods, 90% of them are having a problem with ovulation. But some women who are ovulating regularly, every 14 days they're having a cycle, but still have irregular cycle. Do you know how it happens? Any idea? Right. That is because of what we call luteal out of phase events. That you remember when the ovary, when the egg comes out, that organ change into what we call corpus luteum, which produce progestogen, which maintains the pregnancy if it happens until 12 weeks. When the pregnancy is not there, after about 14 days, it starts to regress and the woman start bleeding. So for some reason, if this luteal phase or corpus luteum regress earlier, they will have a bleeding abnormally. So then they will have irregular period despite having regular cycle, regular ovulation. And also other home endocrinopathies like polycystic ovarian syndrome, hypo or hyperthyroidism, prolactinomas, weight changes, all can affect ovulation, right? And medication that we give like steroids and anything which inhibit dopamine's metabolism like psychiatric drugs and all that, psychotropic drugs we call them, any of those drugs can affect their ovulatory phase, right? Endometrial dysfunction, it's actually a diagnosis of exclusion when we try to find all the other causes, structural and coagulopathies, everything is not there. We call it, okay, it may be endometrial dysfunction. The history will tell us a little bit about that. That is, the patient has a predictable and cyclical bleeding typical of ovulatory. So they, every month, when they blood, day 1 or day 2, they start bleeding. Every month it happens, right? But we can't find a cause, right? And so we don't know exactly. We think about there's a problem with fibrolysis, or there can be a problem with prostaglandins, inflammation, or whatever. We don't know exact. So sadly, we don't have a test to test yet, right, to see whether that person is having. It's when we check everything else, when we found everything else to be normal, we think, okay, it may be endometrial dysfunction, not uterine dysfunctional bleeding. So we are not using the term now, dysfunctional uterine bleeding, DUB. Earlier, in your books, you will have dysfunctional uterine bleeding. That is, entity is not there, but that entity is similar to this endometrial dysfunction. When we can't find anything else, dysfunctional uterine bleeding is what we call endometrial dysfunction. Iatrogenic is that we have given like specially anticoagulant drugs like warfarin, right? And sometimes we give like therapy in a wrong way. Like for instance, if we give notestosterone for 5 to 6 days and stop, you will have a bleeding, right? So we use that knowledge to induce bleeding in some women. If they are not having a period, we give notestosterone for 5 days and stop, they start bleeding, right? So iatrogenic causes, right? And some of the anticonvulsants, antibiotics, smoking, all this can cause what we call iatrogenic, right? That is something we are doing to ourselves. And common one is anticoagulation. Otherwise, non-classified, we know that, we can't find another cause yet, right? It could be a biochemical cause, it could be a molecular. We don't know exactly what's happening. Some of the chronic endometritis, AV malformation, myopathy. So there are so many things still coming up to increase our understanding of abnormal uterine bleeding. So these are all go to not otherwise classified yet, right? Right. So management is very easy. Right. Do you have any question up to now? Before I move to next level, if you want to type, you can type. Right, I'm going to the management now then. Right. Now management option, we can either leave it alone. You just need to tell, this is normal. If somebody's like, let's say a medical student coming to me and saying that, my periods are not coming regularly these days, they come, more than 35 days. I say, I have to just tell her it's normal because you're under a lot of stress these days. Don't worry about it. If you don't get a period every 3 months, take this medicine to get a period every 3 months, at least once in 3 months, then that's enough. And wait for the next period. If it comes in before 3 months, then you just have to keep going like that until you need the proper Once your stressors are gone, you do your final exam, things will be okay, hopefully, right? And others, we have to treat the cause. Like if there's fibroid, we may have to remove it. If it is adenomyosis, we may have to suppress it, like otherwise. And we can treat it medically or we can treat it surgically, right? These are the options we have, right? So for medicine, we have, these are the options we have. We call NSAIDs, non-steroidal anti-inflammatory drugs. Mefenamic acid is the leading one of that, but we have Brufen and other NSAIDs as well. Antifibrinotics is one of our first line drugs, which we call tranexamic acid, right? So that is we use. And hormonal, we can use contraceptive pills. So that is one of the reason we use contraceptive pill in a lot of women who present with problems with bleeding, because that's the easiest thing to do. And usually women need the contraceptive as the added advantage of having contraception effect, also helpful for us. Progesterone comes in pills, injections, implants, or even intrauterine devices, right? And then we have hi-fi stuff like GnRH analogs, which we inject monthly or 3 monthly, right? So depending on what we need, right? Now, the important things you have to remember is that there are few entities where you need to do something. Perimenopause, that is after 45 years, if somebody comes, any of your parents, it may be your parents, your friends, or your aunts, somebody known to you who has any change in period after 45 years, if they have any change in their period, they call you and ask them to get their endometrium evaluated. It's important, number one. Postmenopausal bleeding, you have to be very vigilant, because this 45 years is 1% chance of cancer. Postmenopausal, 10% chance of cancer. So anybody after menopause is no period for 1 year. So after 1 year, if there's any bleeding at any time of your age, it may be 55 years, it may be 95 years. Any bleeding from the genital tract, you need to investigate. That is important. Postcoital bleeding, that is bleeding after sex, bleeding in between periods. Again, you have to check very carefully, because these are the symptoms of usually sometimes cervical cancer, right? However, postcoital bleeding can be due to ectropion, or what we call sexually transmitted diseases also. So don't need to worry too much about it, but need evaluation. You can't just say, that's normal and send home. So intermenstrual bleeding is something you have to be careful. Postcoital bleeding, careful. Postmenopausal bleeding, careful. Right. Now, younger age, especially the less than 18 years, a lot of times you have to rule out pregnancy first, especially nowadays, right? And then whether there's any structural problems or hormonal disorders like Cushing, congenital adrenal hyperplasias, prolactinomas, hypothyroidism, you have to check girls like that. If not, then you can try a little, you can try just, if this is less than 18 years of age, if you have period every once in 3 months, that is more than enough. But after that, you need to treat a little. And if their problem is only heavy menstrual bleeding, during the period time, giving mefenamic and tranexamic acid for 3 to 4 cycles will help the woman, or giving contraceptive pills again. Reproductive age group is different, right? So always it's very common also. So you have to rule out any pelvic pathology, pregnancy, and malignancy. If these are not done, you use just tranexamic acid, mefenamic acid, contraceptive pills, right? And if you find underlying cause like hypothyroidism, polycystic ovarian, you treat that, right? And you can try hormonal or non-hormonal methods for treatment, right? Now, if somebody is having irregular menstruation, that is like polycystic kind of picture, that's when they have cycles which are coming more than 35 days. When they bleed heavily. So these kind of patients, if we give hormonal contraception, right, hormonal treatment, they do better. So they will have a period every month, their period will be less, and they have, they have added advantages like reduction in cancer risk, endometrial cancer and ovarian cancer, if they use contraceptive pill for a year or more. Right? So these are the added advantages. Then we have surgical options. We can, if it is fibroids, we can remove them, especially they are myomectomy. We can now do, without even cutting the womb, we can put a camera inside the womb and take fibroids transcervically. So it's called transcervical resection of fibroid, or TCRF. We can do polypectomy. We can do uterine artery embolization. We can do hysterectomy. We can do endometrial ablation, right? Endometrial ablation is what is still not happening in a very big way in Sri Lanka, but all these things are happening in our unit. Endometrial ablation is in other countries, it's one of the commonest thing to do, because they have gadgets where they put the small gadget inside, and we call it cooked endometrium. They by using heat, they destroy the endometrial lining, right? So these are the things you all have to remember for endometrium. So in the summary, right, proper examination, history and examination, exclude pregnancy, check for anemia. If it is more than 45 years of age, do endometrial assessment. If it is postcoital bleeding or instrumental bleeding, do a careful assessment. Exclude endocrine causes like thyroid, prolactin, and polycystic. Transvaginal scan is superior to transabdominal scan. So if you have the opportunity to do a transvaginal scan, always do it, or it should be have done. And hysteroscopy and biopsy, endometrial aspiration, and we have methods of taking biopsies now, not like earlier days, only DNC. Now we have even outpatient, like we don't need to even put the patient to sleep, like endometrial aspiration, what we call pipelle biopsy. If you come to our clinic now, sadly the clinic is not functioning these days. We used to do a lot of pipelle biopsies, right? So these are important, right? So I will stop with a small question, right? 45-year-old woman presenting with continuous bleeding for 1 month. Abdominal and pelvic examination were normal. What is the next step in the management? Yes. 46-year-old presenting with continuous bleeding for 1 month. You did abdominal examination normal. You did a speculum examination and bimanual examination. That is normal. What is the next step in the management? Yes. Yes. Quickly answer. We have only few minutes more. Brahman.
E.
Sorry? E. Transvaginal ultrasound scan. Why do you want to do that? Because why can't you just give some test or like some testosterone or something like that? Why?
We need to investigate for structural causes.
No, again, I told, like, how old is she?
Over 35, 46 years.
4 years, not 35, 45, right? So above 45, you need to investigate, right? So transvaginal ultrasound scan, because these are like we are doing more because we need to know what is the cause, right? So the next step, these all can be done. That is, if say most appropriate is, I would go for hysteroscopy and biopsy. But next step would be just to do a transvaginal ultrasound. We are not supposed to give any hormonal treatment, right? Again, management. We talk about we have to exclude any pelvic pathology, and then once we can use the first line treatment like mefenamic and tranexamic acid. And if there is underlying cause, again we have to treat, right? We can use hormonal and non-hormonal treatment, right? And you have guidelines for that. You can look into what are the medication for what are the condition. And as I told you, irregular bleeding are best treated with hormonal options to regularize bleeding, right? Okay. Adolescent, I told you, hormonal fractures. We have, these are the medical, we have non-hormonal tranexamic and mefenamic acid. Hormonal is progestogen combined or Mirena, what we call levonorgestrel receiving intrauterine systems, hysteroscopy procedures, right? Last question, I think. Right. 46-year-old woman present with controlled bleeding for 1 month. Oh no, sorry. Right. Okay. So this is, can you remember the simple word play, right? So I told you it's the same question. First one was, what is the next step is the management? What is the most appropriate test? So all this will do a biopsy, but hysteroscopy and biopsy is the gold standard. So we will, if you have to choose, then this is it. But if let's say it's no pupil, if hysteroscopy is not there, I would go for pupil aspiration. If it is dilatation and curettage aspiration is not there, dilatation. Likewise, we go depending. This is a trick in SBAs, right? You read properly. Most appropriate to. Other one was the next step. Now try this question. 35-year-old woman is presenting with heavy menstrual bleeding. I have to. Do you all have another lecture? Hello, at 3:15. Do you have another lecture?
Yes, they have a lecture proposal with me.
Okay. Right. Okay. Right. Okay. So I'm going to stop it now then. Right. I have asked. Right. Okay. So please read this journal article that will tell you about all we discuss in a more detailed manner. So you can write. Okay. Thank you very much.
Recording stopped.